So I have diverticulosis and diverticulitis. Diverticulosis is the presence of pouch-like herniations in the circular smooth muscle of the colon, and it usually happens in the sigmoid colon. You can see here in this picture the sigmoid colon and the outpouches, the little bows that kind of form on the outside of the intestines are the diverticulosis. Diverticulitis is when one or more of these pouches or sacs become inflamed and infected. So what's the difference between the two? As you can see on the far left is a healthy colon, and you can see that there's no bubbles on the outside. In the middle is diverticulosis, and those pouches get fecal matter trapped in them. And then diverticulitis is when they become infected and inflamed. In this picture, you can see the colon and you see all the holes in it. These holes are the diverticulosis. You can see how easy it would be for the fecal matter trying to move through the colon to just kind of fall in there and be hard to make its way back out. So then it just sits in there and the bacteria starts to grow in there, and that's when the diverticulitis comes in because those pouches become infected and inflamed. So some risk factors would be people have a higher risk of getting this after the age of 40. It's because aging can lead to a decreased strength and elasticity of the colon, which results in these outpouches. A lack of fiber and a lack of exercise can cause this, and obesity and smoking can also be some risk factors. A little fun fact is that diverticulitis is the most common cause of a GI hemorrhage because it can rupture and cause a lot of bleeding, and it can also cause peritonitis or septic shock. So septic shock would be whenever this infection just it's so overwhelming, and we need to be watching for signs and symptoms such as hypotension and tachycardia. So some manifestations would be when the diverticular perforate and diverticulitis develops. Our patient could have mild to severe pain in the left lower quadrant. They can have fever, an elevated white blood cell count, and if it's left untreated, the septic shock can occur. Also, we need to watch for intestinal obstruction because with repeated inflammation, the lumen of the colon narrows, so the inside of it gets smaller, and so obstruction can occur. So we need to watch for signs like abdominal distension, nausea, and vomiting. So some subjective data that our patient will tell us, they can tell us that they have constipation and diarrhea, or diarrhea. They'll have that pain in the left lower quadrant. They'll have increased gas. They'll have anorexia, so they just won't feel like eating, and they also might be nauseated. So some objective data would be abdominal distension, kind of like this guy's belly in this picture. You can see that it just looks very hard. They could have a low-grade fever. They'll have leukocytosis. They could be vomiting. They could have blood in the stool, which if it's in that sigmoid colon, then it could be a brighter red because it's more fresh. And they could have abdominal tenderness, and they can sometimes have a palpable mass. So that pouch could get so big that we might be able to fill it. So how are we going to diagnose this? We can do it with an ultrasound. We could diagnose with CT with contrast. We're going to do a CBC on them. We could do a fecal occult blood test and a colonoscopy. And the picture here shows the intestines with a little outpouch on it, which would be that little black circle here. That would be the diverticulosis. And then that is what gets food or fecal matter in it, and that becomes infected and inflamed. So how are we going to manage this? A diet high in fiber. We're going to decrease fat and red meat intake. We're going to increase fresh fruits and veggies to try to get that fiber. We're going to reduce our weight, and we're going to avoid increased intra-abdominal pressure because that pressure can cause those pouches to rupture. So things that can cause that abdominal pressure to increase is straining of our bowel movements, vomiting, bending or lifting or wearing tight restrictive clothing. So we're going to try to avoid all of those things. In acute diverticulitis, the goal of treatment is to allow the colon to rest. So we're going to observe our patient for signs and symptoms of peritonitis. We're going to give a broad spectrum antibiotic. We're going to monitor those white blood cells to make sure that antibiotic is working, because if it's not, we might need to get them started on something else that will work so that infection doesn't cause sepsis. Once that acute attack subsides, we're going to slowly introduce things back to the colon. So we'll start with oral fluids, and then we'll slowly progress up to that semi-solid food, because we don't want to just start with the cheeseburger. We're going to, because then that's going to really irritate everything. We'll just start slow and then progress up to that semi-solid food. So medical management would be most of the time that antibiotics work and the bowel rest works, but in cases of the peritonitis or fistulas or abscesses, we might have to do a bowel resection surgery. Hartmann's procedure is where the descending colon is resected. Like in this picture, you see the descending colon is also, it's cut and it's brought up to the surface to form a stoma, and then the distal bowel is sealed off. Some nursing interventions would be to educate the patient on the disease process and surgery if it's planned. Closure of a lot of times this is like a temporary surgery, and so like a temporary colostomy. So the seat can usually be closed within 6 weeks to 3 months. So we can educate our patient on how to clean it, take care of it during that time. We're going to assess our patient's nutritional status and reinforce their new diet. We could always call dietarian to help us with that. And we're going to assess their pain level, and we're going to provide comfort measures for our patient. So a patient problem could be inefficient knowledge related to the disease process and their treatment. So we're going to educate our patient on the disease process and signs and symptoms of what an acute attack looks like, so they know what to look for in the future. Another patient problem would be insufficient nutrition related to decreased oral intake, because remember, we're going to try to let their bowel rest, so they're not going to be taking in as much. We're going to assess their daily weights, do calorie counts, and monitor their IS&Os. Remember, with daily weights, we do it at the same time of the day, with the same amount on the bed, same amount of clothing, all of that. We're going to monitor serum protein and albumin levels and instruct the patient about dietary fiber or bland low residue diets. So we don't want to irritate that colon anymore. We're going to try to do things without seeds or skins, because that can get caught in those pouches really easily. So some nursing interventions. Some more would be that whenever a colostomy is performed, we're going to have the patient or the patient's family demonstrate that they know how to take care of this. We don't want this to get infected or for the bowel to die. So remember, we want the stoma to be pink and moist, and we may need to get a home health referral, so this teaching can be continued at home. So prognosis for this is, for diverticulosis and diverticulitis, is really good. A lot of times, they heal up good and everything works good later. So that's it. Thank you.